you mentioned all this, some of what you just talked about. Even this season on the podcast, I just interviewed Nikolai Bogduk not long ago about the structure and the magnificence of how the lumbar spine and the sacrum are, completely arranged almost in a way that he described as clever, in his clinical anatomy book. And we've also heard from Eric Hegedus and Chad Cook about the orthopedic physical examination tests, and some of those that are found to be quite valid and quite reliable, and many that are not. So we have a feel that it's important to have a strong knowledge about anatomy and the pathology of it. But this chapter talks about being careful about that and looking at it more from a pain mechanism classification system. How do you marry and reconcile those two contrasting ideas, or are they contrasting?
Thank you for even the opportunity to do this, because I think I've grown up a lot in this area. And where does this fit in? In no way is this competing with pathoanatomical. So I really want that to be understood. I feel as a provider, when someone comes to you because they hurt or they're having difficulty moving, as a provider, we have to, at that moment, decide, should I really be using the pathoanatomical system to guide care? Or should I be considering a different subgrouping method to guide care? Now, pathoanatomical is a necessity in active disease. You got an active disease, please do not be using the pain mechanism classification system to guide the care. If you've got somebody who's coming in with significant trauma and progressive neurological findings, vital signs that are chaotic, or sometimes what we call red flag, I please do not even think that the pain mechanism classification system is at all even relevant at this present moment. So I do feel the pathoanatomical system is there for injury and active disease, and we have to really make sure that people do not have these red flag situations. And if they do, we should be challenging ourselves in what we've learned in accurate diagnosis to guide those initial elements of care and intervening to the point, like sometimes you got to choose surgery before therapy. I don't care what provider you are, you got to be able to make that call, because that is a huge call. Now, let's talk about the people that are beyond normal healing times. Let's talk about the people that didn't have a trauma for the onset of the symptoms. They're a bit episodic. Let's talk about the people that had several bouts already of therapy, chiropractic care. Maybe they're a bit depressed on your intake forms, a little anxious. Maybe their FABQ is high. Maybe they're on work comp. I think at that present moment, we've got to, if they don't have the red flags, and if we're starting to talk about the yellow or orange or blue or black, not to, make fun of that, but I think it's also asking us to guide them in a different way, use a different subgrouping method to guide their care and educate them on why they're still having problems. And at that point, I would ask people to hold your tongue a little bit before you commit to telling them how much degenerative changes are going on within the spine or in the knee, or, wow, your ligament looks a little laxed, or, even to the point where, I don't think you're moving to the best efficiency that you can. I think we have to hold our tongue at that point and really ask if it's relevant. So I really believe you have to have both. I think you have to have and be able to swing both and know. And it's not the be all end all either. Who hasn't served somebody who's had persistent symptoms, because they're in your clinic and they're involved in any type of prevention or follow-up care programs that you begin, and they come in and you look at their leg and you're like, what the heck happened to you? And I fell down the stairs the other day, even though you've been on and off with this person for 10 years of low back pain. It fell down the stairs the other day. This isn't the day for me to have a discussion about their 10-year history of back pain and central sensitivity. It's like, well, did we get an x-ray? What are we doing here? I need to shift gears for that person and stay relevant in the acuity of what's happening. And I should be able to do that too. If someone's in the ER, they have found nothing, and they're a repeat visitor to the ER because they're deathly afraid of what's happening to them. I should be able to also have that discussion of, hey, things look okay here. Everything's fine. You're neurologically stable. We need to really ground and shift gears on either end of that scale. So that's, it's that old song, right? I'm going to do it again. You got to know when to hold them. Know when to fold
Hear
them.
the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.